All right. Thanks to all of you that have signed on here tonight. I'm looking forward to spending a little bit of time with you here tonight. I also want to honor your time. I know it's precious and it's a limited quantity, a limited commodity. So I'm going to do my best to keep this to about 50 minutes tonight. There's a lot of information though. So I'll do my best. I'm going to share my screen so you can see my PowerPoint slides as we go through this together again tonight. If you are hoping to hear about knee pain, you've come to the right spot tonight. It looks like my screen sharing is working too. Prior to COVID, we did a lot of these in-person workshops. It's really easy to interact in that format when we're in the same room together. It's a little bit different doing it online and virtually like this. But like I said to those of you that were on already, we do have a chat button there. At any point in time, you can leave a question. I'll do my best to answer it in real time. If I don't get to it tonight, I will get back to you on that later. And so that's good. Like I said, I'm also going to give you some contact information so you can reach out that way. First of all, just a wee little bit about myself. Why in the world would you want to listen to me? Well, let me just tell you, I'm a physical therapy graduate of the University of Iowa program way back in 1996. So you can do the math. I've been doing this for over 27 years. In addition to the University of Iowa master's degree program, I got a doctor of physical therapy through Evidence in Motion, a group in Louisville, Kentucky, a little over 10 years ago as well. I feel like I was prepared exceptionally well through my graduate school experience, and I've had some great experiences since that time. What you're learning tonight is the result of a lot of years of experience. Physical therapy allows me to see a lot of people with a lot of different problems. Lower back pain is the number one reason that people come and see us. The second most common reason, knees and shoulders are about tied for the number two issue. Can't remember the exact number, but I did a little math once upon a time, and it's something like 20,000 visits that we've had in the past 3 years with people with knee pain. And so you're going to learn a ton of things that you learn through the school of experience. And we've got tons of that. And it's not just me. I collaborate with about 40 different physical therapists and other movement experts within our organization. We've been doing this for a long time. We've just celebrated our 25th year at the end of last year. One of the things we'll talk very briefly about is our unique approach. It's very functionally focused. 3D maps is 3D movement analysis and performance. Your knee operates as a part of a dynamic system of movement. And helping your knee move properly and feel better and function well requires that we understand and utilize treatment methodologies that take advantage of the reality that your knee doesn't exist within a vacuum, but it's dependent upon what's going on below it and what's going on above that. So that's an approach that's really, really important if you're looking to find a solution that lasts. I want to ask a question. And again, I'm going to ask you to hit on this chat button. So I want you to really, most importantly, answer this first question. Is there a specific activity that if you do this, you know that your knee is going to hurt a little bit worse? Okay, is there something that makes that knee pain more prevalent? That is a really important question. I'm interested in your response to that. I see a couple of people already saying something about that. And then secondarily, you can give me a little more information, if you would, about how bad the pain is on the 1 to 10 scale, with 10 meaning emergency room pain. And how long have you been dealing with this? And you can say something as simply as weeks, months, or years if you want to. That first question, what activity makes it worse, is the most important question. You'll understand why in just a little bit. Those next questions don't tell me whether what we're going to talk about would be beneficial for you, but it might tell you something about how long it's going to take to get some benefit out of this. If you've got really high levels of pain on the 1 to 10 scale and it's been around for a longer period of time, the things we're going to talk about are still beneficial for you. It just takes a little bit longer to get to that benefit. So I want you to understand that. All right, so we got, here we go. Esther talks about climbing stairs. Yes, very much so. And Eve said the same thing. Tim said pickleball, and he's been noticing it for weeks. That's actually, weeks is a good answer to that, Tim. I'll tell you why in just a little bit. Rose says taking steps. Esther says she's the one that said earlier that it's climbing stairs, 5 or 6 years. Denise getting out of the chair. Brenda says up and down stairs. Physical therapy at Kinetic Edge, pain level from 3 to 8. One of the things we're going to go in a little bit more detail, Brenda, because you said you've had physical therapy in the past. We're going to talk about things that complement a successful physical therapy experience as well. So that might be of interest to you tonight. Brian says any extra use over 5 years, pain's a 5 out of a 10, so moderate pain. So the question, what activity causes it's important because it tells me what kind of pain you're experiencing. Before I get into that though, how bad is your pain and how long you've experienced it? If you have had it for a long period of time, I'm talking years, and if your pain gets 7, 8, 9, those are things that we know are going to take a little bit longer time to deal with. But if you've been dealing with it for weeks to months and your pain is 5 or below, those are lighter issues. It tells us a little bit about how far you have traveled on what we call the cumulative trauma scale. But I want you to understand this. If you tell me there is something specific that makes your knee pain hurt worse, I'm going to say, well, that's not bad news necessarily, because we know that if there's something specific that reproduces your pain, then it's also reducible. And by the way, I didn't get any of your answers ahead of time. You can see a lot of the same things that you mentioned are problematic. These are the most common reasons people say their knee pain is worsened. Walking, standing, running, squatting. Sit to stand out of a chair is a squat, by the way. Climbing stairs or ladders, working, housework, yard work. Notice there's one commonality with all of those things, including all the things you guys talked about, and it is a weight-bearing activity. The knee is a weight-bearing joint, and the more weight-bearing we do with these kind of issues, the more we notice it. However, I will say it again, if your pain is reproducible, that's not necessarily bad news, because if it's reproducible, it's also reducible. To understand that, I want you to understand a little bit about trauma. When you hear the word trauma, most people think about really bad things, right? Motor vehicle accidents, fracturing a bone, a fall from a high level, those kind of things are physically traumatic. And that's true. Those specific types of trauma we call acute trauma. This is what acute trauma looks like. Sudden tissue damage, and then once the thing that brought on that trauma is eliminated from your body, the body goes through a natural healing progression. And for most people, provided it's not a major trauma, for most people, they're going to improve and heal to the point where they get back below a symptom threshold. That's just the reality. Acute trauma results from one incident, one stressor, and when it's eliminated, the body heals. Acute trauma is kind of naturally something that gets better. What we're going to talk about most of all tonight is not acute trauma, though. We're going to talk about cumulative trauma, and cumulative trauma looks different. This arrow you see growing right there now is something that just took a few seconds when I showed it to you on the screen, but it literally could take months and years to develop. And you can notice at the start of this, below the symptom threshold, there are changes occurring that we're not even going to be aware of because we're not feeling anything. And once it crosses the symptom threshold, most people at that point say, it's not bad. I can feel it. It's not the same as it used to be, but I don't want to be a squeaky wheel. It's bearable. Unfortunately, if we keep exposing ourselves repeatedly to the same little stressors over and over again, day in and day out, from weeks, months, and years, it tends to get worse. And when it gets worse, the pain becomes more frequent, more intense, longer in duration. Now, why do I have these buckets on there? Let me show you the bucket analogy. If you are, like me, kind of a visual learner, this might be helpful for you. I've been a physical therapist for over 27 years. And I would say physical therapy as a profession is not highly labor intensive. It's not like working in a factory, lifting heavy weights consistently. But I will tell you, as a 52-year-old, I need more rest at the end of the day and more rest at the end of the week than I used to when I was half my age. And that's because I'm getting some water in my bucket just because of the passage of time. The water fills your bucket, the first thing we notice is fatigue. And this is, the body isn't meant to last forever. And we all know this to a degree as we age. And so we kind of make excuses for that. We downplay it because it's kind of normal. And as a result, we continue to do the same things and more water fills our bucket. And fatigue then often will give way to something slightly more significant, discomfort. Discomfort is when you say, it's not bad, but I feel a little bit more stiff and sore in those knees than I used to. It takes me a little bit longer to get my body going, or after tasks that are a little bit more stressful, physically stressful, Or if you're on your feet for longer periods of time, you recognize that you need a little bit more rest. More water is filling the bucket, and that's the natural progression. And again, we make excuses for that. We often downplay the significance. We reduce the likelihood that we're going to do anything about it by making excuses for it, and more water fills the bucket. And you can see we're getting pretty close to a spill now. And that's when we pass from this little bit of stiffness and soreness into more substantial symptoms. Pain is a different level altogether. And usually at this time, people say, boy, I don't know that I can deal with this anymore. I'm going to have to do something about this finally. Meanwhile, we've let a lot of water fill our bucket. If we're not careful, we're going to have an overflow. When we have true tissue injury, it takes more time, more energy, and oftentimes more money to make that get better. It can still get better. But the whole idea of today is to learn what you can do to move in this direction, reduce the water consumption or accumulation in your bucket. Here's another good analogy I think that works. If you look in the distance there, rounding the bend, we're standing in the middle of these railroad tracks. There is a train coming. And before you even see it, at some point in time, you're going to start to recognize symptoms that a train is coming. Okay, you might notice just a little bit of rumbling in the distance. Maybe you'll feel some vibration if you're walking directly on those rails. And as it gets closer and closer, those symptoms become more significant. The rattling gets more significant. You hear the whistle, the noise is gaining. And if we don't get off the path, that's a warning that you're going to have some danger heading your way. In cumulative trauma, the signs and symptoms are a little bit different, but it's still a warning sign. And usually we talk about what I alluded to earlier. How significant are your symptoms in frequency, intensity, and duration? And unfortunately, with more pain, we move less. And unfortunately, when we move less, that's not just bad for our joint health, it's bad for our general health. I'm going to quickly go over this, but I want you to impress upon you this. What we're talking about is good for your knees, but it's also good for your general health, because movement, the quality and significance of your movement, has a big impact on a majority of our health-related issues. Heart disease, diabetes, obesity, and depression are all impacted one way or the other by our movement. Movement is exceptionally important. In fact, we're going to talk about the two biggest factors for joint health, which are also two of your biggest factors for general health: mechanics of your movement and your metabolism. Okay? There are three ways to respond when we have a problem. I'm sitting in a home that's 109 years old. I'm in the newer part of the home. We moved in here 9 years ago. When it was 100 years old, we had the insurance company come over and they said, yes, we will insure you, but we're not going to insure that roof. It needs to be replaced. Those shingles are old. They told me there was a problem. And you know what I did? I looked at it and said, that's a big roof. It's going to take quite a few shingles to cover that thing. And I just bought a house and I've got other priorities. And I said, I know it's a potential problem, but I ignored it for a while because I didn't see enough signs and symptoms to say I needed to do something about it. Now, I'm not going to lead you on. I'm happy to report that I did several years later change it out. Nothing worse happened. But if I had waited too long, ignored it too long, I probably would have been left with a more substantial issue that would have cost significantly more money. Unfortunately, though, the first response for most people when they notice there's a problem is we downplay it, we ignore it. And that's the single greatest mistake that people make, because at the early part of a mechanical, a musculoskeletal joint related issue, it's pretty easy to get rid of these things. Now, you are to the stage, if you're here tonight, that you're probably not ignoring it anymore. Unfortunately, most of the solutions that we get when we first raise our hands aren't true solutions. They're just ways to mask or alter the pain. I'm even saying on behalf of much of the physical therapy world, the treatments that we do, ultrasound, electrical stimulation, they don't get to the root of the problem. They just kind of help you manage the pain. I'm not saying that it's necessarily bad in and of itself to do some of those things. It's okay to do some of those things, but I think we also need to recognize getting rid of the pain isn't the ultimate goal. It's getting rid of the problem that has brought on that symptom, the pain. That is the primary goal. And so my goal tonight is to teach you how to get to the root of the problem and to truly solve it once and for all. And in order to do that, you have to understand a key point. We deal with these issues like they are primarily medical. Now, there is a medical component. We'll talk about that later on tonight. There's also a real mechanical issue as well. It's not just a medical problem, it's a mechanical issue. You don't pull up your pant leg and say, oh, look at that. I got a dial on the side of my knee. I'm low on ibuprofen. I just need to give it ibuprofen, and that will take it away again. No, you cannot solve a biomechanical issue with a biochemistry treatment. This requires a movement-based solution because much of the issue is movement-based. I want to tickle at this just a little bit as well. When you hear that you have an inflammatory problem going on, what is your natural reaction to that? If you're being honest, most people would say, well, I can do something about that. I've heard of these anti-inflammatories. I can take ibuprofen. I can maybe even get a prescription anti-inflammatory. Okay. Well, I want you to understand that inflammation isn't necessarily a bad thing. In fact, some inflammation is a very good thing. Inflammation is a normal part of the healing process. You can see phase 2 of a 4-step process is the inflammatory phase, especially with something that is an acute inflammation. The body will start to do things that prepare it to heal, and inflammation is a part of that process. It's the phase that prepares the body for this vasculature growth. And if we stunt that inflammatory process with an ibuprofen and other anti-inflammatory, we're going to stunt the process of developing the vascular structures that are necessary to bring nutrients to those tissues to help it heal and stay well over time. And I think in America, we quickly default to an anti-inflammatory response that in some ways is fool's gold, prevents us from doing the natural thing that helps heal us. One of my favorite authors of all time is C.S. Lewis. From many decades ago, he's written a lot of books. My favorite quote actually came from an essay that he wrote during World War II in the essay called Miracles. And he talks about the magic is not in the medicine. When we talk about helping someone to heal, it's not about the medicine, it's about your body. The medicine is not the magic. The magic is in your body. What real effective treatment does is to stimulate nature's natural functions or to remove hindrances. Okay? So when you understand that inflammation is actually a not natural response to a harmful stimuli, okay? It's a necessary part of your body's healing. Then we need to do things that help that process along. So when we take an anti-inflammatory, we're actually stunting a natural process. We're not stimulating it. We're not removing a hindrance, we're adding a hindrance, okay? So we need to figure out what's the real successful way to stimulate the body's natural responses. To do that, I want you to hear a little bit of story about a lady named Vicky. She was my client coming up on 7 years ago now, 6 or 7 years ago. At the time, she was age 61. Vicky loved to walk. In fact, she walked around her local reservoir daily, if not more than once a day. It was a body, mind experience, body, mind, and spirit experience for her. It was a social experience. She did it with friends. Unfortunately, of recent, she had been dealing with a deep ache in the lateral part of her knee. And when she rested, it felt a little bit better. She rested for a while and then went out and tried to do it again, and it got worse. And she'd done all the normal things. She ignored it for a while. She went to the doctor and got medications that helped temporarily, but not long-term. She eventually was sent for diagnostic testing, which showed some osteoarthritic changes in her knee. And then they sent her to a specialist who said, well, you might need to think about doing a total knee replacement. And despite all these things that they did, the frequency, intensity, and duration of her symptoms continued to get worse. And she didn't want to do surgery if she didn't have to. She'd done all the things you're supposed to do and reduced activity, and she still had issues. And she actually came to me as a last resort and basically told me, I'm kind of desperate. And I'm not going to tell you the whole story now. I'll wait until a little bit later tonight. But we found that her problem was not really a knee problem. The knee was hurting. The knee was getting stressed. The knee had an irritation, but the real problem was coming from elsewhere. It was not the knee that was the problem for her. It was a hip issue. We'll learn why in just a little bit. So here's what we're going to talk about: the most common types of knee pain, leading to a more important discussion about the causes of that knee pain. And then finally, what does successful treatment look like? Okay, let's talk about the knee itself structurally first. The bones of the knee It's your upper leg and your lower leg bone, the tibia and the femur. The femur above is the single largest bone in the human body. Riding on the front of the knee is your kneecap. That's known as the patella. Then the outside of your lower leg is the fibula that makes up one of two of the bones, the less significant in size of the two bones of the lower leg. What you also see on this are cartilage structures. So you've got cartilage between the two bones, the femur and the tibia. This is your lateral meniscus and your medial meniscus. That's a cartilage that helps guide movement of those bones as they bear weight one upon the other. And then you've also got this cartilage that lines the bone. That's called articular cartilage. That same articular cartilage is on the undersurface of your kneecap as well. And you can actually see some there on the inside of your fibula. It is a hinge joint, so it's made to flex and extend. But it is, like all other joints, a three-dimensional object. It does flexion and extension, but it also does some work in the side bending plane, the frontal plane. Only 10 to 17 degrees. And like all other joints, it's a rotational being too, but not much. So you can see the knee is primarily made to flex and extend, 140 degrees of sagittal plane flexion and extension, while we only have 10 to 17 degrees of side bending and 5 degrees of rotation. That's how the knee is designed to move in all three dimensions to some degrees. And it's made to do that. It's created to do that. And it's made to take on stress while doing that. Most of these issues, however, that are cumulative in nature, it isn't one incident that brings them to the point of giving you a symptom. When these tissues are consistently taxed beyond their design specifications, eventually, because of dysfunctional movement that can lead to physical stress, friction, or tension, there's an inflammatory response which leads to pain. That's the mechanical process with that. Now, we're going to talk about how your metabolism plays into that eventually as well. But I want you to understand that mechanical reality. When tissues get stressed mechanically, little by little over time, there are physical and functional changes that will occur. Now, let's talk about three most common types of knee pain. These are all, in many ways, related to each other. What we are not talking about yet is the cause. There's several causes for one condition, and one cause can cause multiple different types of conditions to develop depending on how the body compensates. One of the most common ones is osteoarthritis. We'll talk about that. We're going to talk about injury to the meniscus itself, part of the cartilage structure. And we're going to talk about the undersurface of that kneecap pain called patellofemoral pain as well. First of all, let's look at osteoarthritis. This literally means arth is joint, itis is inflammation, osteo is bone. So where two bones meet and create a joint, if there's an inflammatory response, that's osteoarthritis. Other words you might hear associated with this are joint space narrowing, bone spurs, or osteophytes. The bone-on-bone phrase is really common when you talk to a orthopedic knee expert as well. I want you to understand that the cartilage that I showed you in the previous page, let me show you that again. This cartilage, the articular cartilage and those menisci, going to get back to that. They are aneural. They don't have any nerve endings. So cartilage wearing out is not at all painful. It's not the source of the pain. And therefore, getting rid of that cartilage isn't necessarily going to make you feel better either. People that have arthritic pain in their knee generally describe a deep ache and some throbbing. And it's worse with weight bearing. Guess what? Many of you already talked about the weight bearing issues when I asked you what makes your pain worse. But I want you to realize this. 76% of people over the age of 63 have evidence of MRI, on an MRI of osteoarthritic changes. Only 13% of them actually are dealing with pain. It's interesting, isn't it? So the cartilage is aneural. It does not cause pain. It's not the thinning of the cartilage that is the problem. There are other things, though, associated with that are painful. The outer layer of your bone, called the periosteum, is a very sensitive tissue. That's impacted by the inflammatory response. Edema or swelling, that's inflammation on the bone in and of itself. That is uncomfortable. And then there's something called synovitis. The capsule that surrounds your joint, in this case, the knee, can get inflamed as well. And that is very painful. Okay. It's not the cartilage itself. So curing or fixing with a surgical response, anything that's cartilage related, is not necessarily going to be beneficial for you. And you're looking to function better and feel better. And this is not only true at the knee. Every joint that you can do an MRI or an X-ray of, there's going to be tons of finding amongst otherwise healthy people that don't regularly experience pain. These are all asymptomatic people. At the knee, at the hip, at the back, at the shoulder, at the neck, at the foot, all kinds of changes can be found with diagnostic testing amongst people that have no pain. Okay, and I want this to be a source of hope. We can't change your MRI. We can't change the fact that you have some arthritic changes, but we can change your pain experience for sure. You just have to realize that the pathology is not necessarily related to the pain, and fixing the pathology, therefore, does not necessarily fix your pain either. So we used to think that this osteoarthritis is all wear and tear related, and there is definitely a component to that, and that component is important to manage appropriately. But the other thing we're going to talk about in short detail are metabolic related issues, which lead to other inflammation issues, abnormalities, and so forth. That's osteoarthritis. Let's turn our focus a little bit to those two little cartilage structures between the bones of your knee. This is actually your left knee from a back, actually it's your right knee from a front side view. So there's your kneecap and there's your fibula. This is the lateral or outside part of your right knee. This is the medial or inside part of your right knee. So if we separate those and look down on those cartilages from above, here's what a longitudinal tear of the, in this case, lateral meniscus looks like. Longitudinal means it follows the C-shaped pattern of this cartilage. Now, in this case, this one's been stitched together. That's a repair process. If it's repaired, you need to be non-weight bearing for 6 to 8 weeks, so you don't overly stress that thing. And usually they do that in young people. If it's a bucket handle tear where your knee feels like it's locking, it might be because of longitudinal tear, and that might benefit from a surgical intervention. If this meniscus is injured due to repeated trauma over time, and you are older than 35 years old, most of you on here, I'm sure, are older than 35 years old, it's probably not an acute tear or longitudinal tear of your meniscus. It's probably degeneration that's built up over time. Remember, though, your meniscus is aneural, so it doesn't itself cause pain. Other things that we talked about associated with that can be felt. But if you're younger and you get a knee that catches and locks in place with certain movements, that might be an acute injury to that cartilage, and that may need to be surgically repaired. If it is related to degenerative osteoarthritic changes, this research will show that most surgical interventions done for that are, on the whole, not very effective at helping you feel and function better, unfortunately. And by the way, these things are present significantly in people that have really not much knee pain at all. In fact, there's one study that was done called the sham surgery. They knew there were some arthritic changes impacting the menisci of the knee amongst a bunch of people with this issue. Half of them, they went in and they actually did a real cleanup of that tissue with an arthroscope. And on the other half, they introduced the arthroscope and didn't do any cleaning up. And they actually found that the short and long-term outcomes were no different between those two groups. In fact, the British Journal, medical journal, British Journal of Medicine, did a review of all the studies that have been done on arthroscopic surgeries for degenerative changes to the meniscus and the knee. And they found that it is so poor that we don't recommend it anymore. The outcomes are not positive. There are ways to deal with it, though, which we're going to talk about in just a little bit. Finally, patellofemoral pain, the undersurface of the kneecap. Why in the world would I put a train on there? Well, here's why. Your kneecap is not an independent mover. It can only go where the tracks tell it to go, like a train, okay? And the tracks are in part, and in some cases in a significant way, impacted by what's going on above and below it. Your hips and how they move, your ankle and feet and how they move will determine how that track is aligned, and therefore will determine what kind of mechanical stresses occur to the undersurface of your kneecap. Okay, so these issues are pretty much undetectable on diagnostic testings. Usually it's a more superficial pain on the undersurface of the kneecap as opposed to osteoarthritis that influences the deeper part of the knee. It's a dollar ache, and it tends to be made more significant with stepping activities, particular when you're raising through vertical heights, like stair climbing or ladder climbing. And it is typically the result of poor movement coordination or communication between your hip, knee, and foot. And remember, mechanical stress can lead to repeated frictions that create an inflammatory response, and that's why you experience pain. Unless you fix the movement issue, that's probably going to return no matter what you do, whether it's an anti-inflammatory medication, ultrasound, surgical intervention. If you don't fix the movement issue, mechanical stress will return. Let's shift our focus now from the types to the causes of pain. And when I talk about causes, I'm talking about what are the true culprits, okay? Now, remember, a little bit ago, I talked about every body part is three-dimensional. Your spine flexes and extends. That's the sagittal plane. It side bends left and right. That's the frontal plane. It rotates left and right. That's the transverse plane. Your knee does the same, more substantially with flexion and extension, but a little bit of side to side and a little rotation. And every body part in the human body has to have a balance between mobility and stability. If you have too much mobility and not enough stability, you're out of balance. That's not good. That's going to lead to mechanical stressors. If not at that part, at neighboring areas that compensate as the result of that. On the other hand, if you have way too much stability and not enough mobility, that's problematic as well. So we are aiming for what we call most stability, balance between mobility and stability. And I talk a lot about Goldilocks, right? Goldilocks, the story tells us a lot. She doesn't like the hot porridge or the cold porridge. She wanted the just right. Not too firm, not too soft. She wanted the bed that was just right. At all of your different links of movement in your kinetic chain, from ankle to knee to hip and all the way up, a balance of mobility and stability. Most stability, Goldilocks, just right, is what we're looking for. And when one part is dysfunctional, the closest neighbors are at risk. And so that should lead you to understanding the primary culprits of knee pain that is mechanically oriented. The closest neighbor above the knee is the hip. The closest neighbor below the knee is the ankle and the foot. And then we're also going to talk about one that's not a direct neighbor, it's an indirect neighbor, but mid to upper back issues can be culprits as well. Let's look first at the hip. And by the way, the hip is between your knee below and your lower back above. So if you've had lower back and knee issues, it's pretty likely that there's a dysfunctional issue of some sort impacting your hip. We don't want it to be too mobile. We don't want it to be too stable, right? An overly stiff hip means you have to make compensations for that lack of movement elsewhere. It's usually at the foot, which drags the knee into a position that can lead to mechanical wear and tear. An overly mobile hip means it's moving too much, which takes other things surrounding it, the knee directly below in particular, through an additional range of motion. That again, for a little while is not a problem, but repetitively loading, repetitively asking that joint to operate outside of its design specifications will lead to cumulative changes over time. Okay, and now think about how we treat our hip throughout the day today compared to a couple generations ago. Early America was very agrarian. People worked. They were on their feet, working the earth. The housewives were working all day long on making tasks. Because of ergonomic and technological advances, we're not as active as we used to be. And we sit a lot more than we used to as well. That puts our hips in a flexed position. These muscles are your hip flexors. There's a part of the hip flexor that starts on your lumbar spine. There's a part that starts on the inside of your pelvis. They come and they connect down into your femur. And when those muscles are regularly shortened, the body becomes the position that we put it in. And so those muscles will get tight. What happens when those tight muscles get lengthened? If you stand up, it's going to pull your spine forward, or it's going to pull your pelvis forward, and it's going to tighten itself down in other areas around it, above at the spine, below at the knee. You're going to have to make up for that tight motion. That is a problem with knee-related issues. And you can see that if your hips are positioned one way or the other, it's impacting the position of the knee and therefore the area of the knee that's getting more mechanical stress. And I want to emphasize one more time, it's not a day or a week or even a month. It takes lots of time with little stresses that build this up. The bucket will slowly fill. And so the ankle and the foot is no different. An overly mobile foot creates motion compensations up the kinetic chain, or an overly stiff foot doesn't load, and other places have to make up for that lack of loading at the foot. Okay, so a properly mobile, a balance between mobility and stability at the foot's important. To maintain neutrality here means we maintain a more neutral loading stress up the kinetic chain at the knee and the hip. Foot-related issues have a big impact on the knees and on lower back-related issues. Okay, how in the world does the mid to upper back influence the knee? Well, do this for a moment. You don't hear physical therapists say this often, but I want you actually to slouch, okay? Now, when you slouch, try to rotate right and left. It's hard to do, right? But if you sit up nice and tall, suddenly you feel like you can rotate better right and left. Now, imagine if you just got a stiff and stuck thoracic spine. Every time we take a step, there's movement of our arms that's supposed to rotate our trunk. And if we can't rotate well through there, that motion gets told to go elsewhere. And actually, the thoracic spine is most likely to influence the lower back and the neck. But if you've had lower back, neck, and knee-related issues, the thoracic spine needs to be cleared. Creating a balance of mobility and stability there is really important. Now, I'll tell you, very, very, very seldomly does the mid-back get overly mobile. Some young female gymnasts might have issues with this, but that is a small percentage. Most people need better mobility through their thoracic spine. Okay, so the bottom line is this, folks. If you've had issues with your knees that you have considered or gotten help for, but everyone that you've talked to has just looked at the knee itself, okay, we can do something to that. We can inject it. We can give you a medication. We can do some exercises specific for the knee alone. That's okay, but you need to look beyond to see how all the other parts of the dynamic movement system are operating so that we have just right balances of mobility and stability at each of the links in the kinetic chain, so that we're not asking the knee or any other part to operate regularly outside of its design specifications. So successful treatment, folks, you're not going to be surprised to hear me say that if you want to eliminate the pain, you got to find the true root cause. And unfortunately, the most common treatments do not consider root cause assessments. Anti-inflammatories, injections, and surgeries just get rid of symptoms, okay? And actually, surgeries continue to increase in prevalence. They don't solve problems, they just mask it. If you take away some of the movement of something that hurts with movement, sure, that's going to feel better temporarily. But asking the question behind the question, why in the world is that knee taking on that additional stress? I need to know this. That's really important, okay? And then I also want to point to this. I follow him on Twitter, Dr. Lukes, I think is how you say his name. He's an orthopedic surgeon. He's a rare orthopedic surgeon who is really understands quite well biomechanics, and also has done a ton of research on how much good they're doing and maybe some things that need to be changed within their system. And he says this: every person with knee or hip arthritis needs to hear this. Pain doesn't necessarily imply harm. When people hurt when they move, they stop moving. And he will say the research would indicate that the harm related to not moving is greater than the harm of moving. And I would definitely nod my head to that as well. It's okay to run, walk, and rate train, even if you have some irritation. There is a process that the body cycles through from time to time when the synovium gets a little bit irritated. No matter what you do, it's not easy to make that go away. And most people find that if they just continue to move within 3 to 6 months, it's going to get better. The problem is most people feel like the movement is the issue, so they stop moving. And so in the process of giving it rest, they get weaker, and it leads to a downward spiral that is not positive. Things that people with knee arthritis should not hear are you have bone on bone. It's not reality, and it paints a picture that makes people feel like they have no hope. That's not good. You have the knee of a 90-year-old. I hope you've never heard that, although I know that that gets said quite a bit. You should never hear that you should stop exercising or that you should rest to save your joints. Don't ever go to some place that says you just might have to come back every 3 months for an injection. In fact, injections are correlated with a loss of cartilage and more likely outcome of a surgical intervention that, as we've been learned over time, are not particularly helpful. He says that PT can be helpful. I'm going to tell you what kind of PT is the most helpful. Steroids are typically not helpful. It's best to remain active and just ignore whatever your diagnostic test says. And at this point, there's not a whole lot of research that proves that stem cells are that important and effective either. So my encouragement to you is to stop ignoring or altering the pain and address the root cause. That means we need to look at your body and understand, how are those areas around the knee functioning? How is the ankle and the foot working? How is the hip working? How is your thoracic spine working? And that will allow us to find your individualized issues that we could work over time on changing. You need to have a whole body perspective. Your knee does not exist in a vacuum. It's impacted by everything around it. The process is educational and empowering. What you do today needs to change because your body changes and needs new and different stressors. It is illegal for us to do what we call group multiple people at the same time. I do not recommend it because you can't be individualized. You can't get the right treatment at the right moment to get the right response unless you're doing it one-on-one. It's okay to use hands. I use my hands a lot. Manual treatment is effective for some things, but it needs to be combined with real movement between gravity and the ground. And it often should be focused on areas where there are actually, the culprits that are contributing to the additional stresses on the knee. So I actually spend more time in knee patients helping their hips move a little bit better to take the mechanical stress off the knee itself. And then it also needs to be complemented by a healthy lifestyle plan because these issues are both mechanical and metabolic. So I am not a dietitian or a nutritionist. We need to, as a company, align with one, though, and that's actually one of my goals for the next 12 months. But I would encourage you to research anti-inflammatory diets. Unfortunately, most of the world, and America in particular, there's so much processed foods, and those processed foods, because of what they do for shelf stability, what they do to enable you to get more caloric impact or modifying it, have a lot of factors within there, or cheap production is part of it as well. They have a lot of factors in there that actually stimulate an inflammatory response. That's not the acute mechanical inflammation. This is the chronic bodily inflammation that will make you hurt worse. Okay. You need to move. You need to manage your weight, which is related to diet and movement, by the way. Sleeping, get the proper amount of sleep is really important. Stop smoking and limit your alcohol consumption and learn how to manage all types of stress, physical, emotional, and so forth. The goal is, instead of allowing this tissue damage to improve and increase over time, is to do something to bring it down below that symptom threshold. So I want to tell you that a few things. Our memories are limited. You don't know what your problem is yet. I've taught you a bunch of stuff. You're not going to remember it all, and you don't know how it applies to your body itself. And then, we like to say that knowledge is power, but I'm come to the point where I realize that knowing something isn't very important unless you actually do something with it. Implementation of knowledge is a requirement. And that's what I'm going to offer to you now. For those of you that are willing, you spent a good 45 minutes with me here now. My gift to you is this: 20 minutes with one of our movement experts that can do a mechanical assessment to look at how your ankle, foot, hip, and thoracic spine move, and whether you've got a Goldilocks situation happening in your body. And in a short amount of time, with just a few questions and some brief assessments, you'll understand what type of knee pain you have, what are the core causes of that issue, and then what a process of making it better would look like. And the benefits are, you stop wasting time and money. You learn how to take control of your own health, and you can focus on more natural healings. That's what we want to go for. Now, this has a $150 value. My gift to you is I'm not going to make you pay that. offering it to you absolutely free if you sign up tonight. And we'll have a guarantee. We can't give you money back because we're not taking it from you. But if you find that by doing this, you get no benefit from it at all, just tell us and we will donate to the charity of your choice $150. Beyond that point, there's no strings attached. You do with that what you want. We're here to give you information that's actionable, and then it's up to you whether you want to do that. At the very least, you'll have a summary of what we find so that you know the primary culprits and what a strategy to make that better would look like. Years ago, I would be a little bit more timid in telling people about this. I'm not anymore. There are way too many people that are dealing with these issues for way too long, way too significantly. More people need to hear how to get control of their joint pain. And so I want you to take advantage of that. So here's what you got to do. All you got to do is hit that chat box again and say, I'm in, I want it. And then you need to tell me where. So here are our clinic locations. Which one's closest to you? Ames, Des Moines, Colfax, Newton, Pella, Oskaloosa, Albia, and Centerville. So click on that chat button, say I'm in, and here's where I want to do it. And if you're not close to any one of those, we can do it online too. There's definitely a way to do that. Okay, I got a few people in here. Brian, no, sorry, Brian, that's a previous comment there. Brenda says, Pella, that's great. Esther, where do you want to go? Esther, you're in Pella too. Great, I see that. Karen, Oskaloosa, Brian, closest to Ames. I don't think you live in Ames. Maybe you do live in Ames. Brian, I know you're somewhere up there. Let's see, Lynn's in Des Moines, Rose in Centerville, Charlene, where do you want to be seen, Charlene? Tim wants to do it online. Tim, you'll probably get me then. Carol, we can do it in Albia, Carol, that'd be awesome. Let's see. Charlene's in Des Moines. There you go. Yeah, Brian, that's where I thought you lived. I won't say it to the whole group though. Sheila wants to do it in Centerville too. Great. We got more people signing up. Go ahead and keep signing up, folks. As you do that, know this. Here's my information. I want you to have that. This is my cell phone right here, so you can call or text any questions that you might have. If you want to respond to any of the emails, oh, good. Susan, you're in too, in Des Moines. So you did it right. You're good. You can reply to any of those emails that will eventually get sent to me. But if you want to go directly to my inbox, troyvm at kineticedgept.com is the place to do that. Again, you're going to get another email from us after tonight. It's going to have a link to this thing. I think I started the video. Yeah, I did. So you can watch it again. I'm going to ask you a favor too. If you know people that are dealing with knee pain, Sharon, I got you too in Pella, so that's great. Would you send that email to them with that link? Because more people need to hear about this. More people need to stop spending money on things that are only temporarily reducing pain and not getting to the root of the problem. So if you would do that, I really appreciate that. There is a link on there to sign up for a free screen. I think we still have it on there, but if you've already signed up here by just saying I'm in, you do not need to do that. We will have somebody at each of our offices that you want to go to, give you a call, and we'll figure out a way to do that. And we'll get you scheduled at a time that works very conveniently for you. I think that's pretty much it, folks. Let's see. We had some Q&As coming through. Oh, can a fall onto the knees cause arthritis? Good question. I would say this. A fall onto the knees can create an acute inflammatory response. Whether that yields to a long-term arthritic change depends upon the significance of the damage that occurred during that. So I would say yes. Can it cause arthritis? Yes. The quick answer is yes. Does it always cause it? The answer is no. Peripheral neuropathy, someone else is also asking about. That's an entirely different beast, although it is still impacted by the same things that we're talking about. Mechanical and metabolic related issues. But peripheral neuropathies are something that reduces the sensation that you would feel peripherally, either in your hands or in your legs. It's a different kind of pain, peripheral neuropathy, than arthritic pain. But I would say most people that deal with neuropathies also have arthritic issues, and it alters the sensory experience. So, but peripheral neuropathies will not be exclusively improved by mechanical interventions like we talked about tonight. However, it can reduce discomfort related to that as well. It's a more systemic issue though than our local arthritic related problems. Elaine, chat box, but nothing pops up. So Elaine in Centerville, that'd be great. We can try to get you Elaine in Centerville. That's great. All right, wonderful, guys. Let me stop the share. Good. Gets me back here. I appreciate all the time, guys, that you spent here. And I want to just reinforce that if you have any questions that have gone unanswered tonight, I think I've caught most of them, but please reach out to me. I'm happy to be a resource for you. Even if you don't take us up on the screen right now, if you have issues, reach out. We love answering questions. That's what we exist to do. It's our passion. So we want to help you with that too. Thanks for your time tonight. We did it in 50 minutes. That's awesome. Glad we did that. Thanks for giving me your time tonight. And I look forward to talking to you more. And for all of you that have signed up, thanks for doing that. And I really, really am glad that you're going to get some good assessment of those issues. We'll talk to you soon. Bye-bye.